Thank you. You just heard an excellent talk by Dr. Burkule, where he eloquently described heart failure with mildly reduced ejection fraction, and at the same time also pointed out the limitations of echocardiography in diagnosis this condition because of observer variability. My talk, however, is quite focused, and this is on ARNI in treatment of heart failure with mildly reduced ejection fraction. Now, but I would start with the ESC 2021 guidelines, which classifies chronic heart failure into three classes. And as you all know, the reduced ejection fraction, when the ejection fraction is 40% or less, when we call it mildly reduced ejection fraction, when the ejection fraction is between 41 to 49. And for heart failure with preserved ejection fraction, there have to be signs and symptoms of heart failure with an ejection fraction 50% or more, along with objective evidence of cardiac structural abnormality or evidence of elevated left ventricular diastolic filling pressure. However, the guideline also clarifies that to diagnose heart failure with mildly reduced ejection fraction, although the presence of structural heart disease and elevated LV filling pressure are not mandatory if there is a certainty about the value of the ejection fraction which you get. But still, the presence of these parameters would actually make the diagnosis more likely. However, the ACC guidelines, they say that the presence of spontaneous or provocable increased LV filling pressure is mandatory for the diagnosis of heart failure with mildly reduced ejection fraction. Doesn't really matter which guideline you follow, but once you have diagnosed the condition, how you are going to treat it? Well, the treatment depends on the class, and we know the classes are dynamic. So, therefore, you have to look into the trajectories of heart failure. For example, if the patient originally was classified to an heart failure with the reduced ejection fraction, but with treatment the ejection fraction is improved to more than 40%, then these are not really heart failure with mildly reduced ejection fraction, but they fall into a separate class, which is heart failure with improved ejection fraction. And why is this important? This is important because we know that heart failure with improved ejection fraction has a prognosis which is better than perhaps all the different classes of heart failure. And treatment-wise, we know one thing, that we should not be stopping the medications even if the ejection fraction has improved. On the other hand, if it's a heart failure with preserved ejection fraction, which has deteriorated, and now the ejection fraction is between 41 to 49%, these patients must be treated in the lines of heart failure with mildly reduced ejection fraction. The problem is, when heart failure with mid-range ejection fraction improves with treatment, and the ejection fraction goes up to above 50%, because we are still unclear whether we should be treating this as heart failure with preserved ejection fraction or as heart failure with mildly reduced ejection fraction. We still are unclear about this issue. Now let's move on to the pharmacological treatment of the condition. Unfortunately, there are no dedicated clinical trials involving patients with heart failure with mildly reduced ejection fraction. But there are many clinical trials on heart failure done in the past which have included patients in this range of ejection fraction. And some of these are PEP-CHF when perindopril is used, CHARM preserved where candesartan was used, I preserved with irbesartan, Paragon heart failure with ARNI compared to valsartan, TopCat with spironolactone, IPD meta-analysis on beta blockers, and so on. But what these studies have showed, that this post hoc analysis or analysis of subsets have shown that patients with heart failure and mildly reduced ejection fraction might benefit from the drugs used in heart failure with reduced ejection fraction. So the question is, where is the evidence? Well, the evidence in support of these, there are a lot of evidence there, but it's for want of time, I can't go through all of them. But I will just briefly tell you about the evidence in support of beta blocker, ASERVs, MRA in this condition. And if you look at this meta-analysis, which was published in 2018, it showed beta blockers significantly reduced all-cause mortality and cardiovascular mortality in patients with ejection fraction less than 50%. And this effect was more pronounced if the ejection fraction was less than 40%. However, if the ejection fraction was 50% or more, then the beta blockers were not effective. Moreover, this was only valid for patients who were in sinus rhythm. If the patient was in atrial fibrillation, the advantage of beta blocker was not there. So the study concluded that the beta blockers improve EF and prognosis, but the data are more robust if the ejection fraction is less than 40%. But similar benefit was also observed in the subgroup of patients with ejection fraction between 40 and 49%. Now, if you look at an analysis of the Swedish heart failure registry, it shows that RAS inhibitors, that's ACE inhibitor and ERBs, significantly reduced mortality in those with ejection fraction less than 50%, but not in those more than 50%. This I have just a blown-up view of that. And if you look at the TOPCAT study, where the mineralocorticoid receptor antagonist spironolactone was used, in patients with ejection fraction less than 50%, the primary outcome was significantly reduced. And there was also modest reduction in those whose ejection fraction lied between 50 to 55%. But above that, above 55%, no significant benefit with MRA was seen. So let's move on to ARNI, that is a sacubitril valsartan combination. What evidence do we have for it? Now, we know from paradigm heart failure study in patients with ejection fraction less than 40% compared to enalapril, ARNI was superior in reducing cardiovascular death, heart failure hospitalization, all-cause mortality, and also in improving symptoms. But what about in patients whose ejection fraction was more than 40%? Now, the Paragon heart failure study included patients with ejection fraction 45% or more, and they compared ARNI to valsartan. The primary outcome, which was a composite of cardiovascular death and total heart failure hospitalization, was at least numerically reduced in the group which were on ARNI compared to valsartan. But unfortunately, the primary endpoint narrowly missed the level of significance, and the p-value was 0.056. And this benefit was actually driven by reduction of total hospitalization for heart failure. Now, although the primary endpoint narrowly missed the level of significance, when the pre-specified subgroups were analyzed, there was a suggestion of heterogeneity of treatment effect with possible benefit in patients, those who are at the lower end of the ejection fraction. And also this was seen in women. Now, when the patients were further divided into two groups depending on the ejection fraction, so those with ejection fraction of 57% or less, in that group, the primary outcome was significantly reduced with ARNI compared to valsartan, whereas those with ejection fraction more than 50% didn't. Now, we have to remember that in Paragon heart failure trial, patients with ejection fraction more than 45% were only recruited. Those between 40 to 45 or 41 to 45 were not. Had these been enrolled for the study, the results might have been different, but this is a conjecture. We don't know really. Now, the question again is, what about the effectiveness of ARNI across the spectrum of ejection fraction in patients with heart failure? To answer this question, data from Paradigm heart failure and Paragon heart failure trials were combined. And in the pooled analysis showed that ARNI significantly reduced cardiovascular death, heart failure hospitalization, all-cause death compared to valsartan. Now, the lessons from the study was that ARNI reduced heart failure hospitalization and cardiovascular death compared to RAS inhibitors, and that the efficacy of ARNI varies as per the LV ejection fraction, and greater benefits were observed among patients who had ejection fraction below normal. And therefore, patients with ejection fraction lower than normal, which includes heart failure with mildly reduced ejection fraction, would be expected to benefit from ARNI compared to RAS inhibition. Now, lastly, I'll just speak about SGLT2 inhibitors, though this is not really my topic of discussion, but I think it would be incomplete unless I mention them. In emperor-preserved study, empagliflozin was compared with placebo in patients with ejection fraction more than 40%, and it showed the primary outcome, which was a composite of heart failure, hospitalization, and cardiovascular death, was significantly reduced compared to placebo. And keeping all these in mind, the ACC guidelines has given ARNI a class 2B recommendation along with ACE, ERBs, MRA, and evidence-based beta blockers. And the ESC guidelines has done the same. Now, if you look at these studies, these are not again for mildly reduced ejection fraction, but these are for the preserved ejection fraction, and you would find that the highest benefit, the highest risk reduction was found with empagliflozin in the emperor preserved study. But we have to again take note of the fact that in emperor preserved study, empagliflozin was compared to placebo, whereas in paragon heart failure study, ARNI was compared to valsartan, which is an active comparator. And ARBs like valsartan, and in this case maybe candesartan, in charm preserved study has showed that candesartan, ARBs like candesartan reduce heart failure hospitalization. So this is something we have to keep in mind. So in summary, there is no prospective randomized clinical studies for patients specifically with heart failure with mildly reduced ejection fraction. Most data for heart failure with mildly reduced ejection fraction are from post-hoc analysis from previous heart failure trials. And as we understand, EF is a spectrum. And among patients with EF between 41 to 49% that we now call as heart failure with mildly reduced ejection fraction, patients with ejection fraction at the lower end of the spectrum appear to respond more to medical therapies similar to the patients with heart failure with reduced ejection fraction. Therefore, it is reasonable to treat these patients with guideline-directed medical therapy used for patients with heart failure with reduced ejection fraction. And a subgroup analysis of the Paragon heart failure trial for patients with ejection fraction between 45% to 57%, which I've showed previously, has shown the benefit of ARNI compared to valsartan and all. Thank you.
Thank you. And yes, Suvro, for giving an important input in terms of treatment of heart failure with ARNI in particular and the clinical scenario. There is no denying the fact that we had a number of studies which beyond doubt showed survival benefit, although we have some important points to take into consideration. But this is there, the survival benefit is definitely there in ARNI or SGLT2 inhibitors, the new recent two anti-failure drugs. The important issue that I personally feel is that in most of the trials where survival benefit were reported, the doses used for ARNI was 200 twice daily. But in our real practice, hardly we ever go up to that dose because of two important apprehensions. One, the chronic kidney status. We are afraid of the renal function deteriorations. We are afraid of potassium level rising, and in fact it does so, because most of the patients with chronic heart failure is having a compromised renal function to a certain extent. So because of that only we don't go up to this level. And secondly, hypotension, another important areas. And we are unnecessarily sometimes afraid. We don't like to increase the dose, but if you increase the dose, it has been shown clearly that BP doesn't go down. In fact, it may increase. So these are the two important areas which keep us away from the target dose and probably keep us away from the maximum benefit of heart failure that we could have achieved.
Just one thing, that is, Dr. Banerjee, you have talked about the pharmacotherapy and other things. What about I was talking regarding the sudden cardiac death profile. Sudden cardiac death profile in mid-range or reduced ejection fraction, is there any difference in incidence or it remains same?
Okay, well,
Sudden cardiac death.
I think we do not have the data yet to say whether there's difference between the two. But if you ask me about whether we should be putting in ICDs, of course not, because this is always, ICDs are indicated for ejection fraction less than 35%. And mid-range, mildly reduced ejection fraction would be above 40%. But we have data to say that if the ejection fraction goes lower than 35%, then the chances of sudden cardiac arrest increase. So from that, intuitively, we can say that perhaps the patients with heart failure with mildly reduced ejection fraction would not have as high as chances of cardiac arrest that heart failure with reduced ejection fraction would have. But again, as I've said, I do not think there is any data on that, but this is intuitive.
Any comment from any floor or Dr. Barua?
All this study population, that was, actually it's a very small group of study because most of the results are extrapolated from a bigger studies, like Emperor Preserve trial and this Paragon trial also. And then, so we need a bigger study, but it's difficult to actually identify this and collect this huge number of patients with this mildly reduced ejection fraction. And then it could be an evolving natural history of the disease. And then recently, SGLT2 inhibitor was shown to improve the strain imaging of this patient. And those the study was conducted in an evolving phase of the disease, whether it is actually improving from the reduced ejection fraction or the ejection fraction is deteriorating from the preserved ejection fraction. And or it could be a separate entity. So it's very difficult to actually tell about this.
Yeah.
Dr. Burkule has shown some slides from the nature. That review shows that all patients who are varying between mid-range and lower ejection fractions, in the current scenario, the needs ultra-structural evaluation of this myocardium by contrast-enhanced myocardial imaging, particularly MR imaging or PET imaging. If there is too much of heterogeneity of tissue, the mid-range and lower-range ejection fractions, there is no difference in sudden cardiac death. That means all patients in this range needs some ultrastructural myocardial evaluation to assess sudden cardiac death. This is, I think, published in 2021, and that shows that this all, particularly if there is a history of syncope or pre-syncope or any arrhythmia on Holter, or if there is a history, family history of sudden cardiac death, there are strong pointers that even with 40%, 45%, they may die suddenly. And all these mid-range and lower-range patients needs ultrastructural evaluation of the myocardium.
Yeah, this study is conducted with cardiac MRI, and if the scar burden is very high, significantly high, and the gadolinium enhancement is higher, so it could be an indicator for sudden cardiac death, even in this range of.
And this is blurring the differentiation between reduced and mid-range. And there is a blurred. I think that's why I accepted that Dr. Burkule has created the confusion that this narrow band of ejection fraction, that will 100% acceptable or not? Definitely, that's a big question.
Yeah, I think that is the challenge, as Dr. Burkule has very correctly said. I think, how do we really diagnose patients with mildly reduced ejection fraction? And most of the time, we find that 2 echoes done maybe on the same date from 2 different places would give some variable results.
25% cases of ejection fraction increase in mid-range. Now, who are the 25%? Is it possible to clinically or pro-BNP or it is echocardiography? Even he discussed the presentation of the histology also. Is it possible to predict which group is increasing? 25%.
Okay. So is it possible to predict whether which patients with heart failure with reduced ejection fraction would improve? I think, is that the question? Yeah, I think there are certain parameters where we can actually try to predict that. Firstly, it could be clinical, like certain patients, like for example, those patients who had Takotsubo cardiomyopathy or fulminant cardiac failure, or maybe postpartum cardiac cardiomyopathy, they have chances of increasing more than the rest. And often we find they are back to their previous ejection fraction. Secondly, genetic markers are there. Can't remember those genetic markers specifically, but there are genetic markers. If these genetic markers are present, then they are prognostically bad. Then they have less chances of improving. Also, MRI scan and I think certain other markers can give us a clue regarding which of the patients who are more likely to improve. But we know that if the GLS is very low to start with, these are the patients who are going to improve more than those where the GLS is not that bad.
study available whether RNA is really helpful or not. No study is there.
No, well, it's been there. If you look at the patients with heart failure with improved ejection fraction, they have specifically mentioned that in 3 conditions where the ejection fraction may improve to normal. And not only that, not only the ejection fraction, there are structural improvement as well in that the molecular level. And these are the 3 conditions perhaps where we can think whether we would be stopping their existing medications or not.
Yeah, I think although it is not included in the study, but interestingly, when you are treating a patient of heart failure, we are planning to add RNA to it. But as I told you, we don't give the guideline-derived medications. We keep at 50 twice daily or 100 twice daily, and we're afraid to go above in case the patient develops hypotension or CKD gets deteriorated. In this background, if you look at the SGLT2 inhibitors, there are a lot of studies coming that it can be used in non-diabetics also, like the reduced heart failure study or DAPA heart failure study. The comparison is that outcome where it's almost the same, but in SGLT2 inhibitors, you can fix up the dose. One single dose is its full dose. So that is a very important practical benefit. We don't have to build up the dose, which in ARNI, we have to do it. And if we cannot treat the patients with ARNI with adequate doses, adequate patients, and adequate care, probably the benefit of ARNI will not be achieved in full form.
Just last one question to Dr. Burkule. Regarding non-cardiac events, I think there are some students also, I think this is very important that non-cardiac events in mid-range ejection fraction and with patients with reduced ejection fraction. Is there any difference? Because heart failure is a multi-system disease. It's not only cardiovascular disease, it can affect all throughout the body. It is a multi-system disease. Regarding non-cardiac events and non-cardiac death, is there any difference?
Yeah,
Please comment on it.
Yeah, this is a very pertinent clinical issue and question, because as we know that we are treating the patient as a whole, so we should not disregard the non-cardiovascular mortality. Now, as we know, the HepF population, actually the incidence of non-cardiovascular deaths are higher, like they will die of CKDs, they will die of strokes or the other vascular events. While the mid-range EF generally is more closer to the reps. Okay, so the non-cardiovascular mortality is definitely less than the PEPs, that is for sure. So though their total mortality is more closer to the PEPs, the non-cardiovascular mortality is more closer to the reps. That is the question, because they don't have that much of a comorbidity load as the PEPs have it.
There was quite a high incidence of amyloidosis in EMPIRE trial. Would you like to make any comment on that?
Actually, the amyloids, to start with, I think by the time we see a full-fledged case, their EF is quite low. But most of the time, the radial contractile is so well preserved in the amyloids that they can still be in the PEPs. So I think any new onset of heart failure with a preserved ejection fraction, at the back of the mind, we should always think about an infiltrative cardiomyopathy. And as the question was, which are the patients which may improve on the optimal medical therapy, ejection fraction, in these patients with the MREF, as was pointed out that there is a particular clinical etiology and then the GLS, and the third is obviously the scar burden on the MRs. Those with a higher LG will have more heart failure hospitalization, more deterioration, while those without a scar burden have got a very significantly low incidence of sudden cardiac deaths and heart failure hospitalizations, and an extraordinarily well response to the optimal medical therapy by these 4 pillars. So I think we need a further phenotyping of all these heart failure patients, and just taking EF as our guidance and taking that narrow zone doesn't make much sense.
Okay, all good things.
Just one, I will ask Dr. Borua to comment. What is the future of genomic analysis and your myocardial scar assessment in future? In 2022, we are thinking about it. What is the future? Suppose after 5 years, 3 years, what will be the future of that? Any prediction?
Genomic analysis, basically the gene analysis of this myocardial fibers, and to exactly know how they behave in the future. And then this is actually tagged with different markers. And then this is still in the evolutionary phase. And then probably in that way we can exactly know the geological factor associated with these different types of diseases and the natural history and the progression of the disease. And then it could be the mildly reduced or mid-range that the doubt and this debate still exists. But still, in my personal view, I feel that the mildly reduced ejection fraction is a better term like this compared to the other terminology. And it's obviously this, the second question, sir? Second question is scar burden. Scar burden. Obviously, this scar burden in hypertrophic cardiomyopathy was very well established, and even in non-hypertrophic cardiomyopathy, in fact, non-ischemic cardiomyopathy also, that we have seen that these micro scars that is detected in micro CT also. CT, micro CT can detect micro scar, and then that can also give prognosis of the this kind of patients. And then we have seen during the interventions that we are actually doing the conduction system pacing, and particularly non-ischemic cardiomyopathy patient. When we try to introduce that lead through that septum, and sometimes it actually gets halted there. It doesn't go. And then later on we did the MRI, and then we have found that scar. So these are the non-ischemic cardiomyopathy with scar. So that is also important.
Responsible both for sudden cardiac death as well as for deterioration.
Yes, yes, yes.
Okay.
This physiologic spacing has invited. We are thinking of physiologic spacing by his bundle spacing, and that is inviting something else that we should evaluate the myocardium also. Yes. Otherwise, your attempt to physiologic spacing will be futile.
Okay, all good things should come to an end. Thank you very much, the speakers, my co-chairs, and vibrant audience there. Thank you very much.
Thank you, respected chairpersons and the speakers. And here it is time that we break for lunch. And we will be back ASAP, requesting all the people present here to be back on time, because we really have engaging and interesting sessions post-lunch. We will be back by max to max 30 minutes in this auditorium. Please go enjoy your lunch and be back ASAP. You are finished. We will start the next session by 2:15 itself. Thank you.